Good afternoon, everyone. My name is Deborah Levine. I am the Community Engagement Officer for the City University, the Graduate School of Public Health and Health Policy, and it gives me great pleasure to bring to you today this most important conversation. I'm not going to spend a lot of time on the opening because we have an hour. Just know that this is a two-part series, and we are super excited to have our partners in the room today. Our conversation today is rising rates of congenital syphilis and access to care. Um, we will quickly move through as people are still joining us, but I want to make sure that we have the full hour for this conversation. Next slide. So really quickly, again, just so folks are familiar in using the Q&A feature, you'll see select the Q&A button on the bottom of the screen. You'll see it's right there circled. If you don't see the Q&A button at the bottom of the screen, you can select the More button and a pop-up menu will come up, and you can select the Q&A button there. From there, you can type your question in during the presentation, and we will then share that with Dr. Ivy Turnbull, who is our moderator today, and we are very grateful to have her. She is the director, the deputy executive director of the AIDS Alliance for Women, Infant, Children, and Families, and the chair of the National Black Women's HIV/AIDS Network. Before we get started, as usual, we have a small pop-up questionnaire that is helpful to us so that we know who's in the room and helps with our evaluation. So if you all would just take a few minutes and complete the survey. Sorry, we seem to be having some technical difficulties with the survey, but hopefully we'll be able to get that up between the speakers. So without further ado, I will turn the floor over to Dr. Ivy Turnbull. And again, we're very grateful to have you here as a part of this extremely important conversation. Thank you, Dr. Turnbull.
Thanks so much, Deborah. And thank you to our panelists who you're going to be hearing from today. And thank you from all of the audience members and participants who are joining us today. As Deborah mentioned, this is a two-part series, but this particular session is going to focus on the national syphilis data, highlighting the rising rates of congenital. Now, people say, well, what's the big deal about that? Well, the big deal about that is we have not seen rates of congenital syphilis in this country, and as we are seeing today, in the last 10 decades. And our colleagues who are on the panel are going to be discussing specific issues on why that's occurring, how that's occurring, and what it is that community-based organizations and communities in and of itself can do to get involved. One of the things that I, in discussing what this session was going to be about among my colleagues, was that I said, you know, it's very important not only to provide information, but also to give the community a charge, a call to action. What is it and how is it that community-based led organizations can we can marshal the resources when they're given communities to actually address this issue of congenital syphilis. This past December 1st, we celebrated or commemorated the 35th year of World AIDS Day. And that theme for that World AIDS Day was remember and commit with communities in the lead. Why that is so critical, particularly as it relates to this specific issue, is that working closely with communities and community-led organizations is critical to addressing not only the needs of HIV, but also the issue of congenital syphilis. So I'm here today joined by three of my colleagues. The first colleague and she will address this issue first, is Stephanie Arnold Pang. And Stephanie is the Senior Director of Policy and Government Relations at the National Coalition of STD Directors. Stephanie, as I said before, who's going to be our first speaker, will then be followed by Dr. Kevin O'Callahan from the Division of STD Prevention, HIV Center for HIV, Viral Hepatitis, STD, and TB from the Center of Disease Control. And finally, we're going to hear from Dawn Schuk. Sorry, Dawn, I don't know why I wanted to say Smith, but going to be hearing from Dawn Schuk. And Dawn is the CEO of Sisterlink's Collaboration, a community-based led organization in New York. So Stephanie, can we start with you?
Yes, of course. Thanks, Dr. Turnbull. So as Dr. Turnbull said, I'm going to talk about congenital syphilis from a national perspective with the very uplifting title of The Appalling State of Congenital Syphilis and What to Do About It. Next slide, please. So just a little bit first about my organization. I'm with, as was already stated, the National Coalition of STD Directors. And our vision is a nation where all people can live sexually healthy lives. And our mission is to advance equitable, effective STI prevention programs and services in all communities across the country. And we do this as the voice of our members. Next slide. So who are our members? Our core membership are the 65 STD directors across the country who are funded directly by the CDC Division of STD Prevention for STD prevention. We also have an additional almost 1,500 members that work in clinic settings, as well as 1,800 plus disease intervention specialist members. Next slide. So let's get into our national congenital syphilis data. Next slide. So as Dr. Turnbull has already stated, we have really dramatic and bluntly appalling levels of congenital syphilis. When I started working with NCSD back in 2011, the CDC director at the time had a winnable battle of congenital syphilis. At that time, we had 335 cases of congenital syphilis. This was perceived as an issue that we could eliminate and that we could really invest in and completely eliminate congenital syphilis. And sadly, just since that time has just dramatically increased. We have now CDC released updated data just in November, and last year we had almost 4,000 cases of congenital syphilis, which has been an almost 10%, which is 10% increase in cases since that low level of 2012. And in just this last year was an almost 32% increase from 21 to 22 data. Next slide. And Dr. O'Callahan's going to get into this data a little more, but what the CDC released at that time in November, it stated that 88% of 2022 congenital syphilis cases were preventable. Next slide. And what the CDC data states is that the largest chunk of congenital syphilis cases were result of inadequate treatment. So we often think of congenital syphilis as being a lack of prenatal testing, which is part of the challenges. And as the CDC data said, almost 40% of cases are a result of no timely testing during pregnancy. But we are seeing just this last year a more concern about treatment as well as timely testing. 11% given no treatment, and then 12% other reason or missing data. Next slide. And I want to just emphasize that while we might think of congenital syphilis as being just in certain places, it is everywhere. So this is also a map, from the CDC, and outlines that 70% of the US population lives in areas where CDC recommends syphilis screening for all sexually active people ages 15 to 44. Next slide. So I want to discuss kind of what brought us here. So we have, as we outlined, this really dramatic increases of syphilis and congenital syphilis, but those didn't exist in a vacuum. So I want to talk specifically about resource challenges, both financial resources as well as people power, that has brought us to, unfortunately, where we are today. Next slide. This is a graph outlining the loss of buying power experienced by STD prevention programs since 2003. So while syphilis has increased pretty dramatically, which is the yellow line, we have seen a dramatic 41% decrease in purchasing power of the STD prevention field since 2003. Next slide. And we've also seen, one of the workforce leads that we usually look to for help for congenital syphilis in particular is disease intervention specialists. And in case you're not aware about this workforce, they are the backbone of public health, and it is their job to ensure that patients who are infected or have been exposed to an infection such as STDs are notified and treated. STIs. I'm trying to change my language to be a little more updated. And we were pleased to get from Congress an additional $1 billion in COVID funds allocated to the STD prevention sector in 2021 to build up this workforce. We saw during COVID that disease intervention specialists and the need for that workforce, as well as contact tracers, to track infections and act as those, for lack of a better word, disease investigators to find out and stop the spread of infections. But unfortunately, earlier this year, next slide, yep, that one, thank you. The debt ceiling deal that was released in June between Congress and the administration defunded $400 million from the disease intervention specialist workforce that we had received during those COVID funds. It was considered unobligated funds, if you remember the conversations from this summer. And so the last 2 years of that funding has been rescinded, and we are now back to losing FTEs for DIS that are perfectly situated to be addressing congenital syphilis. Next slide. And so what we know from a very recent survey of our membership, that the loss of these last 2 years of funds will as meaning a loss of at least 1,100 positions. There's 630 FTEs that will be lost at a minimum in 2024, and an additional 164 FTEs lost in 2025. And perhaps one of the other bigger items is that there were 500 additional FTEs that this handful of the surveyed participants of our membership plan to hire, but are no longer able to because of the loss of this funding. And while we obviously this workforce was embedded in STI programs, and contact tracing syphilis, congenital syphilis, and COVID, there were also grave impacts on HIV, hepatitis, and drug user health as well, because these positions are really a syndemic approach to these infections. And so this will impact not just the STI and congenital syphilis response, but as well as these other infections. Next slide. And this is just one example of the direct impact of the loss of these positions to congenital syphilis. This large city on the eastern seaboard stated that they had used their money to support their response, which had seen an 80% increase in congenital syphilis cases, but they will have to be discontinuing these activities as a result of the rescission that is being implemented now. Next slide. So in addition to the workforce and financial challenges, we also have, unfortunately, treatment access challenges. Next slide. So just a brief Bicillin 101, if you're not intimately involved with the treatment guidelines for STDs. Bicillin, which is the official name of this drug, is the only drug that's approved by CDC to treat syphilis in those who are pregnant. It's an injectable drug, and it is also very expensive if you're not a certain type of 340B provider. And the drug is currently in shortage. Bicillin is a challenging drug and has been actually in shortage 9 of the last 20 years. So we have limited workforce to address our congenital syphilis rates, and currently right now a limited supply of the key drug in order to prevent congenital syphilis in those who are pregnant. Next slide. So just to outline again the dramatic cost of this drug, the 340B program is a federally run drug pricing program for certain type of safety net providers. And those providers can get Bicillin for 20 cents. This is very affordable for them. But if you're not a 340B provider, if you're a regular private provider or other providers, then you're talking on the open market, we're paying $1,200 for, I believe this is a box of 10 syringes for Bicillin. So obviously this is a very dramatic difference and greatly impacts the access to drugs for different types of providers. Next slide. So we have also done a recent survey of the impact of the Bicillin shortage. What we are finding is that clinics across the country do not have Bicillin and have been dramatically impacted their ability to order their needed and projected needs for Bicillin. And this has led to delays in treatment for those who are pregnant, somewhere between 1 day to 28 days in our survey data. And I just want to emphasize that there is really no delay in care for syphilis in those who are pregnant that we should consider acceptable. Every single case and every single test has implications for the longer that you delay treatment. So even if a pregnant person eventually does get treated, there can be grave impacts to them and their pregnancy as a result of the delay in treatment. In my head, I think of this as, 10 years ago when I joined NCSD, we were having conversations within the HIV prevention world of at what level at what time would you put a person who is living with HIV on HIV treatment drugs? And that is just not the way that we approach HIV any longer. We really attempt to get people onto treatment right away after they test positive, once they've acquired HIV, and keep them on treatment for as long as they can be. And that's really something we need to bring to syphilis as well, is just this understanding that there is no delay in treatment, which we should find acceptable. There are challenges to the alternative treatment for treatment of syphilis. If you are not pregnant, there is another recommended oral drug, but we have concerns about adherence and how often people have to take that for somewhere between 2 weeks to 4 weeks, depending on their stage of syphilis. And it can have gastrointestinal challenges as well. It is a very effective drug when used as recommended, but we do, like I said, have adherence problems. And we are very concerned that this is really only going to get worse. Pfizer, who makes Bicillin, has stated that this shortage should abate in second quarter of 2024, but we'll see. We're getting into the winter. We have other infections that Bicillin could be used for, and we'll see how increases of RSV and other infections could result in increase in Bicillin usage. Next slide. So as Dr. Turnbull said, we want to focus on action. These are depressing statistics and depressing state of where we are with congenital syphilis and public health in particular, but what can be done? Next slide. The first is to educate providers and the partners that you work with on increasing syphilis. So we want to make sure that this is getting out these increasing rates, and the reality of increasing syphilis and congenital syphilis is well known. The second is any place where an individual interacts with people who are pregnant is an opportunity to test. CDC in their missed opportunities data from just last month emphasized the need to use and expand the use of rapid syphilis testing. And then we also need to, so the third point, work to ensure the immediate treatment of pregnant people once they do test, if they do test positive for syphilis. And the other item that I would note is just to raise the visibility of the needed additional resources for public health programs and the important role that public health programs and disease intervention specialists in particular play in addressing our congenital syphilis crisis. Thank you very much. I think that's the end of my presentation. I think we'll now turn it over to Dr. O'Callaghan.
Thank you so much. And give me 1 second to let me just share my screen, and then okay. So you should all be able to hopefully see my screen. So my name is Kevin O'Callaghan. I am a pediatric infectious disease doctor by training, and I work in our surveillance and data science branch in the Division of STD Prevention in CDC in Atlanta. And mostly I spend all of my time working on infections in newborns in the STD realm, but most of my time, probably 95%, on congenital syphilis. And so I'm going to go over some of the data that was presented in the last presentation with some, I think, additional detail, looking at some of the more granular aspects of what the syphilis and congenital syphilis epidemic looks like in the United States. I will say, just as a declaration, that I have no real disclosures, and some of the conclusions I may state here do not necessarily represent the position of CDC. One disclaimer I will make is that this data does contain self-reported data from persons with syphilis who on their self-reported race and ethnicity. Any differences in rates or impact of syphilis are not due to biological causes, because races and ethnicity are not biological infrastructures, they're social structures. But they are the result of systemic inequities and disparities that are linked to that race and ethnicity. And similarly, we strive to use sort of gender encompassing language, and most of the time I'll try to state pregnant persons for persons who are pregnant, and birthing parent for those who have delivered a stillborn or infant. When we do sometimes use maternal as an adjective in our data, and when we do say that, it should be understood to denote features of the birthing parent, agnostic to their self-reported gender. So we'll start with the acquired syphilis data. So this is the data on just sort of syphilis in adults who acquired it through sexual contact. And it's a necessary precursor to talking about congenital syphilis, because obviously infants who get congenital syphilis get it from a birth parent, and that birth parent got it through sexual activity. So in order to understand why rates of congenital syphilis are increasing, we need to understand the dynamics of syphilis in adult populations. The last full year of STD or STI surveillance data from 2021 that was published earlier this year. Our full 2022 data is coming in January of 2024. I will be referring to some of the preliminary 2022 data because it was published last month in that MMWR that was mentioned in the last presentation. But in 2021, across the US, there was over 175,000 cases of adult acquired syphilis, which represented a 74% increase since 2017. This disease, syphilis, and particularly the earlier stages of syphilis, what we call primary and secondary syphilis, which are the symptomatic stages that occur within a couple of weeks to a few months after the first infection. When we look at primary and secondary syphilis, what we see is that rates have increased in both men and women in the total bar here, but really men are overrepresented and have been overrepresented going back to 2012 and in fact earlier. Men are impacted with 25 cases per 100,000 men as compared to 7.3 cases per 100,000 in women. However, the rate of rise is quite different. Cases in men are going up about 23% year on year, 2020 to 2021, but cases in women are increasing 55% year on year. And if we look at this red line, this represents what we call a rate ratio, which looks at the ratio of cases in men versus women. What we see over here on this right-hand bar is effectively describing for every one case that's diagnosed in a person identifying as a woman, how many cases are identified in a man. So 1 to 1 would be one case in a woman is correlated to one case being reported in a man. 1 to 2 is one case in a woman is correlated with 2 cases in men, etc. And what we see when we go back to 2000, when really this most current epidemic of syphilis really started to take off, it really started first in men. And we see the rate ratio going from 1 to 1 to 1 to 2, or sorry, 2 to 1 to 4 to 1, all the way up to close to 16 to 1 by 2012. And really what that tells us is that in the first decade of this new millennium, this new epidemic and this burgeoning epidemic really was impacting men more than women. And that was because of spread in sexual networks of gay, bisexual, and other men who have sex with men. But what we see now in the last few years is that our rate ratio is dropping. And so we've gone from about 12 to 1 down to about 4 to 1, and this is continuing to drop. And what this really indicates is that this epidemic is accelerating in women. And relatively more women are now getting syphilis. And year on year, as this increases, what it means is that there's increasing transmission in heterosexual networks, and more women who have sex with men are getting infected. When we break this down by women aged 15 to 44, what we use is our sort of reproductive age cutoffs, acknowledging that women under 15 and over 44 can get pregnant. What we see is that when we break it down by age range, we see the highest current rate of 23 per 100,000 in women aged 25 to 29, but rates are accelerating fastest actually in women aged 35 to 44, the oldest cohort within this age range, at an 81% year-on-year increase. But obviously, all 5 of these age groupings within this reproductive age category are increasing, and they're increasing faster now than they were in the early 2000s. When we look at this early syphilis rate among women of reproductive age, what we see is that going from 2012 to 2020, with dark blue being worse rates, rates are increasing everywhere. And really, there's not a significant portion of the country that is spared from these rising rates over time. And when we do a direct comparison of 2012 to 2021, what we see is that most places in the country have gone a rate of 0 to 1 cases per 100,000 women in this age range, now up to somewhere between 10 and 100. And you can also see that when we look at it at the county level, if we look at counties in the United States that report at least 1 case of syphilis in women 15 to 44, this used to be a disease process that was isolated to our urban areas, but now we see expansive spread across rural areas of the United States as well. When we think about race and ethnicity disparities for primary and secondary syphilis, we do see significant rate differences, and we know that this disease has differential impact across race and ethnicity groupings by self-report. And so some of the worst impacted populations in the United States tend to be persons identifying as American Indian or Alaska Native, who've had a year-on-year increase of 74% in the 2020 to 2021 period. But in the last 5 years, they've had an over 300% increase in their cases of primary and secondary syphilis. And close behind them really are persons identifying as Black or African American and Native Hawaiian and Pacific Islanders. And so we know that there is real and significant differential impact of syphilis in adults based on their self-reported race and ethnicity. When we look at the congenital syphilis data, and I hope the adult data has given you sort of a good overview and precursor of what the CS data is going to look like. And as you might imagine, as I mentioned, because congenital syphilis is predicated on syphilis in persons capable of pregnancy who themselves have syphilis, we're going to see some similar trends. And when we look at the congenital syphilis data going back to the early 1940s, 1941 being the first year it was a notifiable disease in the United States, we see that in the early penicillin era, we had a steep drop off in cases of CS because penicillin is highly effective at preventing the outcome of congenital syphilis. We actually reached a nadir, as the prior speaker mentioned, in the early 2000s, where really we were in a position where syphilis was likely eliminatable in the United States with significant effort. And for a variety of reasons, those elimination efforts really never took hold and were never acted upon. And what we see is that starting from the 2010s, we do see this start of a rise of congenital syphilis that is really now accelerating and becoming steeper. When we look at the last 10 years, these blue bars here represent just the total case count of cases of congenital syphilis. In 2021, that was 2,855 cases. We now know that in 2022, as I'll show you in a moment, we are at 3,761 cases, a 30% increase, and a particularly steep increase. But this rise in cases of congenital syphilis really does mirror the simultaneous or the parallel increase in primary and secondary, those early and most infectious stages of syphilis in women aged 15 to 44. So really, this is the epidemic of congenital syphilis really is being driven by this epidemic of acquired syphilis in persons of reproductive age. In terms of what these cases of congenital syphilis represent, about 2/3 of those born alive have no documented signs or symptoms. And that's really one of the nuances of congenital syphilis, is that it's often quite hard to diagnose. Many newborns who do indeed have syphilis after having contracted it in utero may be born with minimal or no symptoms. And so it requires sort of really deep and thoughtful investigation on the part of clinical providers in the perinatal period to understand what the individual risk for an infant is and to ensure that they are doing testing on birth parents when indicated. The remaining third of those born alive will have some signs and symptoms that can be quite extensive. And then there's a not insignificant burden of early infant death and stillbirth. In 2021, we had just over 200 combined stillbirths and infant deaths. As you'll see in the 2022 data, this is a problem that is also getting worse. 89% of all jurisdictions that report data to us report at least one congenital syphilis case in 2021, and that is also, it's over 90% in 2022. The rates of reported cases by year of birth, similarly to those maps that we looked at for primary and secondary syphilis in women of reproductive age, again, we see that the rates really have increased across the country, and there's no significant geographic region that is spared by the epidemic of congenital syphilis. And when we consider self-reported race and ethnicity, I think this really draws out the disparate impact that syphilis and congenital syphilis have persons reporting race and ethnicity that are Black or African American, Hispanic, Latino, or American Indian or Alaska Native. So on the left here, we see the percent of live births in the United States in 2021, and infants born to white, non-Hispanic parents represented just about half of all live births throughout the United States that year, but only represented about 27% of cases of congenital syphilis. Compare that to infants born to birth parents who identify as Black or African American. They represent 14% of all live births, but 31% of all CS cases, representing a highly significant disparate impact that's really about twofold higher than it should be for Black and African American birth parents. And similarly, for American Indian and Alaska Native birth parents, who represent only 0.7% of live births, they represent 3.6% of the cases of CS, which is really about a 5-fold disparate impact of congenital syphilis on persons reporting as AIAN. And I think when we take it as a crude number, what we see is that AIAN persons now have an impact of about 384 cases per 100,000, which is by far the highest rate of congenital syphilis among any self-reported race and ethnicity grouping. And just to bring this to real impact, in 2021 and 2022, this brings this down to really about close to 1 in 150 live births born to American Indian and Alaska Native birthing parents will be impacted by congenital syphilis. So talking about prevention opportunities, how do we tackle this? We consider every case of congenital syphilis as sort of a sentinel public health event and as a significant failure of the public health system to provide optimal prenatal care, identify syphilis in pregnancy, and offer treatment. And in the past, we've developed what we call missed opportunities frameworks to really identify for each case that's notified to the CDC every year, what's the one single thing that really prevented treatment of syphilis for the pregnant person and the possible prevention of the case of congenital syphilis. We've published this before in our surveillance report. If any of you have ever looked at our historic annual STI surveillance report, you may have seen this slide, which really tries to identify what was missed or what was the opportunity that could have been used to prevent a case of CS for each and every case. For the vast majority, it's that they received no timely prenatal care and additionally no timely testing in pregnancy, or they did not get adequate treatment. This past November, we really tried to take a look at how can we better use this data. As you can see, this slide, I think, is pretty text dense, and the messaging around it wasn't particularly straightforward. So we really tried to simplify this cascade of care to identify simple and easy to communicate opportunities for intervention at each and every step. And so really building this into just a straightforward test, treat, and outcome cascade for syphilis care in pregnancy. What we developed looks a little something like this, but I'll definitely walk through the data. So for the 2022 data, for example, of the 2,800 or so cases of congenital syphilis, about 40% didn't have a documented timely test, meaning they were just not tested for syphilis early enough in pregnancy. And early enough in pregnancy really is just anytime 30 days before delivery. And they just did not receive a test in time to allow them to be adequately treated for congenital syphilis before delivery. However, about half did get a timely test, but of those, the vast majority either got inadequate treatment, meaning they didn't get penicillin, for example, or they got no treatment. And this really represents the bulk of missed opportunities across the board. So when we published this vital signs in November, what we looked at is how does the 2022 data look different and what opportunities are we missing? And as mentioned previously, we've seen a 10-fold increase in the burden of congenital syphilis across just 10 years, going from 335 cases in the US in 2012 to now 3,761, which in and of itself represents a 30% increase over the prior year. And we see that here, this accelerating rate, which again is mirrored by the rates of primary and secondary, those early stages of syphilis among women aged 15 to 44. And as I mentioned, our rates of stillbirth and infant death continue to increase, going from around 196 to now 231 stillbirths in 1 year, and 51 infant deaths. I will also call out that one of the significant impacts of syphilis is that it does lead to early pregnancy loss and miscarriage, and that is not captured in this data. So there is an additional burden of loss here that is over and above the deaths that are identified. When we look at this data, and I think this was mentioned previously, about 9 in 10 cases of congenital syphilis could have been prevented through one of these three, highlighted in red, which are a timely test or adequate treatment. The really gaps in testing and treatment represent the single largest opportunity for us to intervene, to get tests to pregnant women earlier in their pregnancy, link those tests to adequate treatment that is provided early enough in pregnancy to treat their syphilis and to prevent a case of congenital syphilis. We also recognize that these missed opportunities are not uniform across geography or across self-reported race and ethnicity. So for example, no or non-timely testing is the most common missed opportunity in the Northeast and the West, meaning that in these two census regions, pregnant persons who should be tested for syphilis are not getting a test, are getting no test in pregnancy, or not getting a test early enough in pregnancy so that they could be offered and receive treatment to prevent congenital syphilis. Compare that to the South, where many people are getting a timely test, but there are gaps in linking them from that test to adequate treatment. And we see similar non-uniformity across race and ethnicity. So no or non-timely tests are the most common causes in American Indian Alaska Native persons, Native Hawaiian Pacific Islander, and white non-Hispanic persons, representing probably a lack of access to simple care, even just testing. Whereas for Black or African American pregnant persons and Hispanic or Latino pregnant persons, they are getting tests, but then there are some barriers that exist between the test and getting them to treatment. And more work needs to be done to understand what these barriers are and how we can resolve them. And I think one of the big things that we learned from this data is that prenatal care is obviously a critically important part of prevention, but a lot of care is happening for pregnant people outside of prenatal care. So one of the things that we do note is that even for those who had no documented prenatal care, about 1 in 5 or 20% still received a timely test during their pregnancy for syphilis, meaning they were receiving care elsewhere, and that represents an opportunity for further intervention. Stemming from this work, we made some recommendations that I think have already been alluded to. One is to really refocus on geographic risk. Using geography to inform who should be tested for syphilis, it has a number of benefits. It allows us to destigmatize testing for syphilis and allows us in appropriate venues to move away from personal risk and investigating personal risk and making people feel stigmatized for being offered a syphilis test. Using this goal of getting primary and secondary syphilis lower than 4.6 per 100,000 allows us to really recommend offering testing in counties that cover 72% of the US population. Similarly, we need to take better advantage of alternate venues of care outside of traditional prenatal care. One of my mantras is all care in pregnancy is prenatal care, and you don't need to be a prenatal care provider to provide prenatal care. So if you're being seen by emergency room physicians, substance use disorder clinics, jail intake settings, or maternal child health programs, these are all opportunities to screen for syphilis. And as was mentioned before, to address that gap between a test and treatment, especially in the South and in persons identifying as Black, African American, or Hispanic and Latino, rapid syphilis testing could really be a game changer. It could allow us to get relatively immediate results on the day of testing rather than waiting days for results, and then eliminating that gap to care for treatment that is experienced by a lot of persons across those geographies and self-reported race and ethnicities. So I will pause there and hand it over to the next speaker.
Dawn, I think you're the next speaker.
I'm ready.
Okay, great.
I'm going to be brief because I want to be sure that people are able to ask questions for the last two speakers, and because I'll be speaking the next time as well. So there's been a lot of talk about the numbers and stuff, but I'm going to talk to you about how we can engage this population. So Sisterlink started out as a community action for prenatal care coalition funded by the New York State AIDS Institute. That is actually how I know Ivy. She ran the one in Brooklyn, I ran the one in Harlem, and we had two sister programs in Buffalo and the Bronx, respectively. Our whole job was to engage HIV-positive pregnant women into early prenatal care to reduce perinatal transmission. This is the same population. You can go next slide. By the way, my name is Dawn Schuk, as it said on the screen right there. So when the program was not able to be funded after 2013, I recognized that this model that the AIDS Institute had created, hi Pat, I know you're out there, could work on other populations. So over the last 10 years, I have worked with victims of human trafficking. I built networks for that. I built networks for veterans, but always coming back to my first is high-risk pregnant women. And then I started getting alerted of this data. So basically what we do is we develop a diverse network of both health providers, supportive providers, so that we can engage these women and not connect them just to the agency, but also connect them to people at these agencies. We act as a centralized intake. Our outreach team actually belongs to the network organizations, and we work with them to pay them kind of incentive payments. We are always working in continuous quality improvement. Pat Doyle, who was the director, once said to me, we can never be perfect, but we can always be better. And that's what we strive to do. So I have, next slide. So we train our outreach workers. You can actually even go to the next slide. And we engage these women literally where they are. We find them hanging out at the nail salons, the laundromats, if they're just hanging out on the street corners. It's not about giving them a flyer and just saying, here, go. It's about building the relationship, recognizing that each one of these clients are going to have co-occurring issues. They may not be going to prenatal care because they may have substance abuse problems. They may have mental health issues. They may not have housing. These are all things we need to understand when working with them. And there's a lot of talk about meeting them where they're at, and that is extremely important. They may not have eaten for 3 days, so that's the priority before we get them, hi Pat, before we get them into prenatal care. We don't judge. It could take 3 or 4 times before we can get somebody engaged, but we don't drop out on them. We're also the link for if someone gets lost to follow up. Our outreach workers tend to know where to go to locate somebody. I've been known to hit the streets and look for clients to make sure we can get them back to follow up care. That's another important aspect of the network. We have linkage agreements, we have MOUs. They can reach out to us and say so-and-so didn't show up, and we can send out the outreach team and try to find them. Next slide. A network is a living, breathing thing. I can tell you there's a format, but there isn't really a format. It's really going to depend on each organization, how you're going to build that relationship. What I will say is diversity on everything is key. Diversity in your outreach team, that means men and women. I know it sounds crazy when I say men, but there's certain communities, I need the male outreach worker to connect before I can even get near the client. I have a care coordination team, and my most important is my consumer advisory group, because they let me know the places where we really need to do outreach. And we also make sure that the diversity includes mental health programs, substance treatment programs, food pantry. I wish I could do something about housing in this city, but that's Mount Everest right now. Next slide. We train all the time. CAPSI had the enhanced outreach worker training, but since then, my director of outreach, Mariam Hussamuddin, and I have worked on other ways to develop outreach as we move into social media and things of that nature. We give trainings throughout the year based on the things that we're hearing in the community. So if people saying they're seeing a rise in fentanyl abuse in some of the pregnant women, then that's what we're going to do a workshop on. We do trainings in the organizations that we develop relationships with, because we want people to connect with staff at various levels. The most important person at most of my health centers is the receptionist. How she responds to my client is going to make a difference if they stay or if they run. Some people from the organizations, like I said, will be added to our outreach team. And for clinical, this has always been something I'm trying to continually work on and get better, is get trainings for clinical staff so that they are doing testing. I've been an OBGYN for 35 years now. I've been working in women's health. So I reached out to some doctors and I got varying answers. I have one doctor in Borough Park that she tests her clients at their first visit and their third visit. And then I have other doctors that never even occurred to them they should test, even though it's mandated by ACOG. So that's something I'm going to work on a little bit more. Next slide. So this is the most important thing, is listen to what the client is saying to you. Again, no judgment, understand. And then the last two, I always make sure that anybody involved in the network or outreach workers are performing some kind of self-care. It's very easy to see yourself a lot of times in these clients, maybe where they've been, how they got there. So self-care is important. I'm also big on informal gatherings, so informal communication. I may show up one day at an agency with donuts and just shoot the breeze with everybody, and that's how I'll find out that there's some changes in the population that they're seeing. Or I'll just throw a holiday shindig. Pat knows I like to feed people. So I think those are important, because it's not just about the client, it's about treating everybody within the network with respect as well. Next slide. That's me. So any questions you have, I will leave for the other speakers, and I hope to see all of you on the next one on January 10th.
I want to thank all of the speakers. Your presentations were absolutely fabulous. To add to Dawn, you know, the Community Action for Prenatal Care model, right? There are elements of that model that can really apply to what Stephanie talked about in her What Can I Do section, and what Dr. O'Callahan talked about in terms of looking at different ways of engaging and identifying women and bringing them into care. So I appreciate the connection and all of the work that each and every one of you have done. I have a question before, maybe it's a comment, before we actually start the question and answer period. And, you know, many of my colleagues across the country, we have a huge concern. As we looked at the rates of congenital syphilis, those rates now outnumber the the rates and the cases of babies being born with HIV in this country. The however for us is, when we begin to see those kinds of rates within congenital syphilis, for us, the next step is, or the next question is, could we begin to see those same kinds of rates or similar rates with babies being born with HIV? So anybody can answer. What do you think?
I can kick it off. I'm not an epidemiologist. I'm a political scientist by training. But I mean, I think that it's a very good thing to be watching. What I would make the note and make a difference between the HIV transmission and the syphilis transmissions is that HIV transmissions, while I'd also note that my understanding is that the HIV transmissions have been increasing in women. So I think that this is this is a good canary in the coal mine for perinatal transmission for HIV as well. This HIV, my understanding is HIV rates in women hasn't been quite like the primary and secondary syphilis amongst women. So I think that as Dr. O'Callaghan talked about, the sexual network is infections in sexual networks is different. But I think that this is definitely an example of needing to watch this within our systems and public health systems, because everything seems to be increasing in infections in women, and monitoring them. And I'd note that, you know, the investments that have been made in our HIV network for reduction in transmission, particularly in the perinatal, has been a huge success. And hopefully that's a network we can continue to lean on to ensure that that the increases in HIV in women don't lead to perinatal transmission increases as well.
Right. I agree, Stephanie. Dr. O'Callaghan, you want to say something about that?
Yeah, I think it is striking that while rates of syphilis and congenital syphilis have continued to increase over the past 10 years, true HIV rates in newborns are not just static, they've actually continued to fall over the same time period. I think that the risk factors are obviously the same. I do think, Stephanie alluded to, I think the sexual network piece of it is important. And it's very clear that syphilis has really strongly entered many sexual networks of women who have sex with men. And probably differently than the way HIV is entering those sexual networks. But I think this is definitely a canary in the coal mine. And if HIV was to strike a foothold in those same sexual networks, this would be of major concern. I do think that there are different options for prevention of HIV transmission than there are for syphilis, which is one of our big struggles. The therapeutics for syphilis haven't changed in 100 years, really. Neither has the testing. And so we're really stuck in a place where we haven't had significant improvements in the science around syphilis in the same way that we have with HIV. And so post-delivery prophylaxis for infants, you know, obviously it was a game changer and remains a game changer for prevention of syphilis infection in infants. We just don't have similar innovation in the syphilis space. That's a real problem. And I think that's something that really needs to be addressed, both on the testing and the therapeutic side.
Thanks a lot. I know we're getting very close to our hour. I'm looking in the question and answer section. Dawn, do you want to say something about that while I look at these questions to see if anybody could answer?
I've been thinking about what you said ever since we had our conversation on that Monday about the increase in perinatal transmission. I actually do have concerns about it because it's the same populations that we're talking about. And now that that Dr. O'Callaghan's talking about how syphilis treatment hasn't changed in 100 years, I'm wondering if it will, especially with, I'm trying to wrap my head around these numbers. I think that's part of what it is. But yeah, I think the big issue is going to getting people out of their silos and collaborating. that's the hardest thing. Sadly, there's more than enough patients for everybody. And we really need to start getting together and really getting women's health care is the #1 issue across the country right now. And we know that women of color are always impacted by these issues. And when you show me data that says that they got inadequate treatment, it just feeds what I already know. And so how do I change that? This is where I'm thinking now, how do I work on changing that within the clinical community? Because that's a failure on the clinical end. And then how do I empower these women to engage their clinicians to make sure they're being tested? So, I mean, I have concerns about gonorrhea now too, but I'm going to throw that in a completely different workshop. But yeah, I think we can do it if we build the networks. I think we could do it nationally. That's my big plan. Anyway, so which questions are you picking from the?
Well, I'm looking at the questions, and the majority of them have seemed to, the panelists have seemed to responded to. Other than the questions that are related directly to New York, those questions will be answered or followed up with at the part 2 of this series. I'm still looking. I mean, one of the questions has to do with a media campaign. Where are the media campaigns stressing the urgency of women getting tested for syphilis?
So what I can say about that is that I know New York State has a statewide committee that is working on trying to figure out, this is how all this came about. And they're working on it. It's probably going to be well into next summer before they come up with things. So I don't see a media campaign unless I can get one of the pharmaceutical companies to fund that for me. But you're right, it needs to be done. We do need, we have generations that have been educated about HIV and even hepatitis C. How much does the younger generations actually know? The millennials know about syphilis. I mean, I knew about it at Planned Parenthood when I started working there at 18, but to be honest, I didn't think 35 years later I'd be a part of this conversation. Did I hear though, can you breastfeed if you have syphilis? I'm assuming not. Can you?
You can. It's not a. It is not a contraindication to breastfeeding.
Okay.
The only exception to that, and this is incredibly rare, is if a person had a syphilitic lesion on the breast. That would be really the only way that you could effectively transmit syphilis from a person who's lactating and breastfeeding to an infant who is breastfeeding. It's also a rare circumstance because you would have to it would have to be newly acquired syphilis in a person who had just delivered, and so it's certainly possible. But just having syphilis in and of itself is not a contraindication to breastfeeding.
All right, thank you. We are really at the hour. So I want to just thank you all again for participating as panelists. The information that you shared was absolutely distressing, but it was also very, people have to know, we all have to know what's going on with the populations that we care for. And if community doesn't know, then how do we actively engage them in coming up with solutions? So I appreciate what each of you have presented here today. As part 2 will be held in January on the 10th. And I hope each and every one of you who've attended part 1 coming back and join us for part 2. With that, thanks so much, Deb and your team. Thanks again, Stephanie, Dr. O'Callaghan, and Dawn, and all the members of the community who were on who joined us for this webinar. Thank you very much.
Dr. Turnbull, thank you for taking the time, and on behalf of the National Black Women's HIV/AIDS Network for participating, the New York City Department of Health and Mental Hygiene, Sisterlink, the National Council of STD Directors, Youth Connect, we appreciate you all and thank you very much for this very informative conversation on behalf of the City University Graduate School of Public Health. We have a closing survey. We'd ask you to please do that. We hope that you will join us for our next webinar. 2024, we are putting forward a webinar series based on all of the input that you have given us based on questionnaires. You'll have part 2 for this. We're also building out our cannabis equity conversation. So please stay tuned, reach out to us. You'll see that the feedback poll is up. So if you would just take a few minutes and complete that for us, we would be most grateful. You will also get a email from us with the link of this recording, along with a link for the PowerPoints. And if there are additional questions that come up, please feel free to send them to us so that we can see how we can incorporate them into part 2. So thank you very much. We appreciate you all. And again, if you have the time, please complete the survey. Thank you, speakers, for all that you do for our community. And thank you, Dawn, for sounding the alarm and bringing this to our attention so that we can continue to bring some light and hopefully some solutions. And that is us for the top of the hour. Thank you very much and look forward to the webinar email coming out with all of the additional information. Thank you.
Have a great day, everybody.